Greetings, everybody. This is Dr. Weaver. I wanted to take the time to go ahead and oh, do a recording voiceover on the lower respiratory tract disorders. It's about 100 and something slides, like probably 110-ish slides, or maybe close to 120 actually. And so I'm not sure how much time we'll have in class to really go through each of these topics because there are several, as you all know. Anyway, so I'm going to we'll be speaking about slides 1 through 67-ish in class, but slide 68 onward, I will do the voiceover on, and I'll get this to you as soon as possible. So I'm already sharing. Let me go ahead and do this. All right. Uh, it's a recording. All right. I'm going to try to show you guys some pictures when need be in order to make things a little more clear. And so I may be referring back to the textbook. I may have to Google some images to hopefully again help you to understand what is actually happening with these disease processes. Similar to what I would do in a classroom. But of course, me being in this being on this recorder alone, I don't get the questions from you, but I think I have an idea of what things you might need clarification on. So let's talk about asthma. Asthma is one of those lower respiratory tract disorders because it is with the structures rather in the lower respiratory tract is what is affected. Asthma is characterized by chronic inflammation of the airways and hyperresponsiveness of the bronchial smooth muscles, or something we call bronchospasms. And remember, when we talk about hyper responsiveness, we're talking about exaggerated or extreme narrowing of the bronchioles. All right, which of course the problem with that is it's difficult to get air in and out of the respiratory passageway. Now, because of this hyper responsiveness of the bronchial smooth muscles, remember the bronchi, it has a smooth muscle in the respiratory tree, if you will. And as you know, muscles they contract, they also dilate. But in this case, they are constricted. Um, and of course, this is again, it narrows the airway. And if the airways are narrow, then that air that should be exhaled becomes trapped. All right, it becomes trapped in the lower respiratory structures. And because of that narrowing that leads to trapping of air, we refer to this as an obstructive disorder. Now, inflammation occurs in part because things that trigger asthma, which we refer to as asthma triggers, cause the release of those pesky substances that we call histamines and also leukotrienes. And you guys know what that does by that what they do by now because we went over it so much. Now, the symptoms are intermittent. They come and go, and they're generally reversible. All right, which is how we distinguish between COPD and asthma, which we'll kind of go over that. But like if you give a treatment and the patient improves, typically we can say it was an asthma situation as opposed to one of the COPD disorders. All right. So these patients, they do get a break from time to time. They have these periods of normal airway function. Some people they develop permanent changes in the airway, meaning with all that inflammation that is going on in that lung tissue, it changes the tissue. Over a period of time, and we refer to that as remodeling because those cells essentially have changed. So we refer to it as remodeling. And of course, this is going to lead to progressive loss of lung function and it won't be as reversible at that point. And this is one of the reasons why we like to minimize that inflammation as much as possible. Hence the reason why we give these patients the corticosteroids, which diminishes the inflammation. Now, many patients develop this disorder in childhood, as you all likely know, especially if you have children, and some people they do outgrow it. But there is a significant number who develop symptoms later on in life. Now, children with asthma should be counseled on not smoking because this can increase the risk of recurrent disease when they get older. All right. Now, asthma may also complicate chronic bronchitis or emphysema, which is your COPD, referred to as COPD. Now, asthma is classified as a mild, a moderate, or severe based on the amount and type of medications required to control it. So when you think about that step approach that we talked about, I think it had like 6 steps. That first step, you have minimal um, airway reactions, and so there's really no treatment. But once you get to the sixth step, that's when it's pretty severe. So it requires a whole lot more the long acting as well as the short acting and the corticosteroids, the PO by mouth type of medications. All right. Now, the cause of asthma would be it can be hereditary. It can be due to airborne allergies, pollution, as well as smoking. All right. Um, so think about like your pollens, your mold. All of this can lead to um, patients, their respiratory system responding adversely. Now, viral respiratory infections are also contributing factors to asthma diagnosis and also exacerbation. When we talk about exacerbation, basically we have these episodes of asthma attacks that keeps coming on. So it's like an exacerbation. Now, smoking, as I mentioned, air pollution, also early use of antibiotics. If patients who become sensitive to house dust, mites, and also cockroaches have also been linked to asthma development. All right. Also consider cat and dog dander. And other possible triggers would be like your viral infections, people who become emotionally upset. Exercise can bring about an asthma attack or trigger. Stress. Certain medications, such as aspirin and beta blockers. Remember, to certain beta blockers, I believe propranolol or Inderol is one of them. Remember, Inderol, it affects the beta 2 receptors on the bronchial smooth muscles. And so when you give these adrenergic drugs, these adrenergic beta blocking drugs, they stimulate the the receptors on the bronchial smooth muscles and causes them to bronchoconstrict, thereby decreasing airway, um, um, the lumen or the size of the airway. That causes patients to have difficulty breathing, of course. Um, Now, asthma symptoms are intermittent and are often referred to again as attacks. Attacks may last from minutes and it can go as long as days. The patient does experience and will report wheezing, lung sounds, and the wheezing is due to especially those smaller airways that have become very constricted. All right. They also may report chest tightness, dyspnea, or shortness of breath. They may complain of coughing, and also difficulty just basically moving air in and out of the lungs because, again, you have that hyper responsiveness or that exaggerated narrowing of the airway passage way. Now, symptoms are often worse at night. All right. Some patients experience coughing, but no wheezing. Once initial symptoms are controlled, however, airways may remain hypersensitive and prone to asthma symptoms for many weeks. Now, on examination, you will note that the patient has an increased respiratory rate as he or she attempts to compensate for this narrowed airway. So the respiratory rate will be increased. When I say that, so you have to start thinking about acids and bases, right? Because if I'm breathing rapidly in the beginning, then I'm blowing off a lot of CO2. And so these patients may initially become respiratory alkalosis. All right. This wheezing is inspiratory, is expiratory, and you have to document both when you auscultate breath sounds. And this is because of that turbulent airflow that is trying to squeeze through, if you will, those narrow and swollen airways that also has a lot of secretions. So this is what causes the wheezing lung sounds. Sometimes you can just be standing right next to a patient, and without using your stethoscope, you can hear them actually wheezing. Now, air is trapped in the lungs, and expiration then becomes more prolonged because they're trying to expel or exhale the air. All right. Now, cough is common and may produce thick, clear sputum. These patients also, and I want you to really pay attention to this, they may also use their accessory muscles of respirations to breathe. And when that happens, it basically lets you know that this asthma attack is pretty severe, and it is going to require some very quick attention, medical attention. All right. Those accessory muscles of respirations, all right, the intercostal muscles and what have you. You'll see the patient just really struggling to breathe. All right. Now, there's another concept I want to introduce to you that is referred to as status asthmaticus. And don't get this confused with status epilepticus. So, status epilepticus is just continued seizures. But with status asthmaticus, we're just talking about, again, we're talking about asthma and it's repeated, it's prolonged. Bronchospasms are just not controlled and the symptoms just continue for quite some time. Now, as the patient increased their respiratory rate to compensate for those narrow airways, carbon dioxide is going to be inhaled quite a bit. And as I said, if you exhale enough carbon dioxide, the patient initially becomes respiratory alkalotic or respiratory alkalosis. Now, if the attack is not resolved and the patient's respiratory muscles of respirations begins to tire, they won't be able to compensate any longer. And so, for that reason, the PCO2 or the carbon dioxide is going to begin to increase because they're not able to blow off the CO2 any longer because they're tired. The muscles are tired. They're getting into some trouble now. All right. And this will result eventually in respiratory acidosis. And let me show you something here real quickly. Sometimes when you look at signs and symptoms, and you may see where the author lists, let's say, respiratory alkalosis, and then afterwards it will list after that particular symptom, it may also list respiratory alkalosis, or rather acidosis. And you'll say to yourself, well, how can it be both? It's because initially, when the patient has respiratory issues, they're going to breathe very fast, so they're blowing off the CO2, right? And so they become alkalotic. But as the patient, as I mentioned, patient gets tired and they can no longer blow off that CO2 as they did in the beginning, then they begin to be CO2 retainers, or the carbon dioxide retainers, and therefore they become more acidotic. And so it's just what they are first, and then what they will be down the road if they do not reverse what is happening respiratory wise. When these patients become, if any patient, no matter what the respiratory condition is, if they become their accessory muscles respirations becomes very tired, right? They are headed towards respiratory failure, and they're likely going to require a ventilator if we don't turn things around. Otherwise, it can lead to death. Right. Take a look at some of the diagnostic tests. The diagnosis is based on the patient's report of signs and symptoms, also based on your physical examination, as well as spirometry results. And when we talk about spirometry results, we're making reference to there's a device called a peak expiratory meter. All right. This device actually measures the peak expiratory flow rate as well as the forced expiratory volume in 1 second. Right. And each of these during an asthma attack are going to be reduced, especially when these patients are symptomatic, they're going to be reduced. All right. Now, as far as the peak expiratory flow rate, this measures the maximum speed of air a patient can forcibly exhale after taking a deep breath. Right. That's dealing with the PERF, or peak expiratory flow rate. Now, the PEV1, this measures the amount of air exhaled in the first second of a forceful breath out. All right. And so when these numbers again are reduced, then we know that the patient is in trouble. Now, asthma, I think I mentioned this already, but asthma can be differentiated from COPD during spirometry testing. All right. After we administer one of these adrenergic agonists, such as albuterol inhaler. See, so we're trying to determine if the patient is having an asthma attack or if this is due to a COPD, i.e., bronchitis or emphysema. And so we give these patients one of these adrenergic agonists like the albuterol inhaler, and then we retest these patients. So we give the medication, all right? And remember I told you that asthma symptoms can generally be reversed with medications, but COPD cannot. So if I give this patient this medication and then I retest them with these spirometry devices, they will improve if it's asthma. All right. So hopefully that makes sense to you. Now, allergy skin testing and increased serum immunoglobulin E, as well as eosinophil levels. Remember, your CBC gives you eosinophil results. But if these levels are increased, it indicates that there's an allergic reaction involvement, right? It's due to maybe some pollen or dust or something like that, right? And it can also, knowing this, of course, if it's an allergic reaction, it can help us determine what the appropriate treatment might be. Now, arterial blood gases is when we take blood from the arteries instead of the vein, may also be evaluated during a severe asthma attack. Remember, I told you that if someone is breathing very fast in the beginning because they're trying to compensate, or they are compensating, we're doing the ABG, and that ABG is going to show respiratory alkalosis. But then, if we did not get that attack under control, and we do an ABG, then it will show respiratory acidosis. So we may see alkalosis initially, and then once we see acidosis, we know that this patient is not compensating very well. All right. Now, on a long-term basis, Asthma control can be evaluated using these two devices that I talked about. So frequency and severity of exacerbations and also nighttime awakenings, since this asthma occurs a lot at night, um, as well as frequency of short-acting beta agonists can be used. All right. And this is on a long-term basis. We're using these tools basically, and we're providing the patient with the short-acting respiratory drug, and that pretty much tells us how um, how or the shape of the patient is in. All right. Now, the patients must learn to manage their asthma typically in the home setting. They can monitor and manage their symptoms, and if they are able to, and they do it appropriately, then these hospitalizations can be avoided, and the acute episodes of asthma attacks can be reduced as well. And this is why we have to do a lot of teaching so that these patients can adhere to the treatment regimen. Now, one of the things we certainly want to teach our patients is to avoid triggers. Once they know what the triggers are, for example, they may say if they go into a friend's house who have cats or dogs, and the dander can be a trigger. So don't go to that house, right? Um, and or whatever the other triggers might be. So the patient, again, the patient is instructed to identify what the triggers might be and avoid them as much as possible. And there are times, of course, the triggers cannot be avoided, and so the patient at that point is instructed to use the bronchodilator as prescribed. But the key is they must use the bronchodilator before the exposure. All right, not after or during, but try to use it before. Remember, we're trying to prevent. Now, now inhalers can be especially useful before exercise. If you know you're getting ready, remember exercise is a trigger as well. So before you exercise, say you're getting ready to do a spin class, uh, take your inhaler first so you can broncho dilate, get that air in and out. All right. Avoiding animal dander, as I mentioned. Avoid certain foods that may be a trigger when possible. Also, eliminating carpets and curtains in bedrooms, using vinyl mattresses and pillow covers, and also installing a portable essential air filter that can reduce the dust mites exposure. Maintenance of indoor humidity, trying to keep the indoor humidity of your home about 40 to 50% can also reduce mold growth. The higher the percentage of humidity, then the more likely that mold will grow in that environment. Now, if the cold temperatures also trigger symptoms, then the patient should wear maybe one of those, maybe like the little ski mask that covers the nose and the mouth. That would be recommended if they're outside in cold weather. Also, they should avoid smoking as well as being exposed to secondhand smoke because that can bring about um, an attack as well. Now, aspirin and NSAIDs can cause asthma symptoms in some patients. All right, so they should be avoided. Beta blocker medications such as your propanolol, I think that's your Inderol, as well as your metoprolol, which is used typically for high blood pressure or hypertension. They tend to block the receptors, the beta 2 receptors on the lungs. Preventing the sympathetic nervous system from promoting bronchodilation. Remember, when the sympathetic nervous system is in play, the bronchioles will dilate because remember that fight or flight. This person is going to need more oxygen to come into the respiratory system because they need it to fight or run. right? But when you take these medications, they stimulate those receptors that are located on the lungs, the beta 2 receptors, and they cause bronchoconstriction. Right. So you have to really be careful about using these drugs. And they're likely going to test you on this. This is a favorite with respiratory disorders. Um, they want to know if you know not to give propranolol or inderol or metoprolol because they can cause the smooth muscles of the bronchi to constrict. All right. And so they should be avoided because they can make the symptoms certainly worse. And by the way, this is one of the flow meters that you see here in the picture here. That's just one of them. I'm sure there are others. This is important here. So all patients, of course, benefit from learning to monitor their condition and make treatment decisions based on hopefully you have taught them well. This can be done by carefully monitoring the symptoms, by monitoring their peak expiratory flow rates, as you can see in figure 31.8. The peak expiratory flow rate is a measurement in liters per minute of the amount of air a patient can blow into a peak flow meter from fully inflated lungs. Now, the patient determines his or her baseline flow rate during symptom-free times. And so what that means is when the patient doesn't have symptoms, they should they use the flow rate just to see what their numbers look like, see what their values look like when they're symptom free. This way, when an attack occurs and they, doing the using this device to determine where they are at that point, they know how far they are from their baseline. All right. Now, if symptoms worsen or the peak flow meter begins to fall below the patient's baseline, because see now you know your baseline, the patient should begin to self-treat according to the asthma action plan, which is located in Figure 3110. Now, if treatment does not improve with the flow meter to some expected degree, the patient should go to the ED or the emergency room. Now, the flow rate results may indicate the onset of asthma before the patient experiences any obvious symptoms, and so it's a way of helping you to anticipate or to prepare for an actual um, um, episode or exacerbation. Right, that's the key. You want to head it off, be proactive. Physical activity as well as breathing exercises have been shown to be beneficial to symptom management, and so and also improve the quality of life of patients with asthma. So it should be encouraged. And this is a nice little peak flow chart that you can document your findings, and that way you can take this to the doctor's office so that maybe your medications have to be adjusted. Now, take a look at the therapeutic interventions. As far as medications are concerned, using the SABAs or the short-acting bronchodilators alone is no longer recommended for adults as well as adolescents. The bronchodilators alone is not recommended. All right, you need more. All right, so these patients might be placed on that along with inhaled corticosteroids, such as Flovent or Pulmicort. These are your steroidal inhalers, and they're generally given in order to control that inflammation. And you really want to control the inflammation in the lower respiratory tree because you don't want permanent remodeling or changes in the structure of the tissue. Now, we should instruct the patient that corticosteroids must be used regularly to prevent symptoms and that they do not provide immediate relief during an acute attack. because remember the corticosteroids, it takes a little time to reduce the inflammation. So we use the short acting bronchodilators to give more immediate relief, to bronchodilate those constricted airways. Now, the long-acting beta agonists, bronchodilators such as Surivant and Floridil can also help prevent symptoms by keeping the airways dilated for up to at least 12 hours or more. So this should be incorporated in the care as well. They should be used in combination with the inhaled corticosteroids. For example, Advair, Advair. Also with what is this? Budesonide and Symbicort. Those are some of your corticosteroids. All right. Now, if inhaled medications do not control the symptoms or the patient has symptoms that occur at night, oral anti-leukotrienes may be added. Remember, these are the drugs that stops the leukotrienes from causing the tissues, our lung tissues, to swell, right, which will cause an obstruction of the airways. And so we give these oral anti-leukotrienes to inhibit of these substances, which will decrease the inflammation and open up the airways. Immunotherapy, such as allergy shots, especially if the eosinophils and the immunoglobulin E are elevated, and once it's identified what the allergic elements are, then it would be appropriate to get allergy shots. To hopefully minimize these allergic reactions. Now, an acute asthma attack may be treated with an inhaler. They're called the MDIs or the NMTs, or basically the short-acting beta agonist, or I call it SABA. Um, and Yeah. So your oral corticosteroids would be like your methylprednisolone, your prednisone. These are your corticosteroids, and these are some really potent, really strong anti-inflammatory agents that are useful in patients who are having an acute episode. But because of their side effects, remember I said that these are very potent, very strong agents. They should be avoided for long-term use. You give it during those acute episodes, but then they should be tapered over a period of time and not abruptly discontinued. Otherwise, it will throw a patient into an Addison's crisis, all right, because the adrenal glands is not making enough of the natural steroids, and so if you take away the synthetic steroids too fast, then the adrenal glands will not be able to respond accordingly. Remember, we talked about that negative and positive feedback mechanism. And if you need more information on that, let me know. Now, it is important for patients to understand the difference between the long-acting maintenance medications, something they're taking daily to keep them dilated, and with a reduction in inflammation. So they should know the difference between those medications that helps with the maintenance versus the rescue medications, and of course use them in the right way. All right. Remember, the rescue medications are more so like what will give us more immediate relief. Oxygen is generally not necessary because many patients they do hyperventilate during an acute attack. If, however, the attack is prolonged and the patient begins to become cyanotic, right, or if their O2 levels begins to decrease based on the ABG, oxygen therapy would be warranted at that point. So I do that. All right. So let's turn to cystic fibrosis. Cystic fibrosis. We're turning our attention to another lower respiratory disease process. Now, it is important that when you think about cystic fibrosis, think about what's happening with the lungs and what's happening to the pancreas, and you'll understand as we go through it. But just want to say that at the outset, keep your mind on those two um, organ systems because you'll see how both are affected with patients who have cystic fibrosis. Now, cystic fibrosis is a disorder of the exocrine glands that affects the lungs, the GI tract, as well as the sweat glands. And I did provide you, I don't know where I put it. So an exocrine gland is a type of gland that secretes substances through ducts onto an epithelial surface, such as the skin or the lining of the digestive tract. All right, usually it's secreting substances through a duct, like a pipe that leads to the surface. All right, to some surface. Now, these glands produce and release substances like sweat, saliva, digestive enzymes, as well as mucus. So it just gives you an idea of what an exocrine gland is. Now, in this disorder, abnormal sodium and chloride. Remember, sodium and chloride actually are together, right? If somebody's chloride is low, more than likely their sodium is going to be low. Or if the sodium is low, vice versa, the chloride is going to be low as well. But in this case, the sodium levels are low. There's abnormal sodium and chloride transport across cell membranes, and so sodium and chloride cannot cross the cell membranes. And when that happens, it causes secretions to become thick and tenacious, right? Um, and and this is what actually caused a lot of the symptoms you see with um, uh, cystic fibrosis. Now, these sticky respiratory secretions are very difficult to remove. I mean, just think about it. They're sticky. The consistency of these secretions are sticky, and they're difficult to move, to be removed. And as a result, it causes airway obstruction. All right, this mucus uh, it blocks those really tiny airways and becomes because they are sticky and tenacious. The patients are typically not able to remove um, the mucus and whatnot. So because of that, air is going to be trapped, right? And also because of the sticky secretions that it's difficult to remove. Um, that those secretions become a great place for microorganisms to grow. So these patients, they also have frequent respiratory infections. All right. Now, that's the respiratory tract. Similar abnormalities in the pancreas also block the ducts. Remember the ducts that leads from the pancreas to the small intestine. They also become blocked, right? And because they're blocked, the digestive enzymes, like the amylase and the lipase, they become retained within the pancreas. They can't make their way to the small intestine, right? And of course, when someone well, let me kind of back up. So the retained enzymes digest and destroy the exocrine, those ducts that are part of the pancreas, right? Because when those enzymes are released, uh, their job is to eat or to break down. So they break down the those tubes, if you will, that leads from the pancreas to the small intestine. All right. Now, the absence, and I think about this too, the enzymes, those pancreatic enzymes that are supposed to break down your fats and your proteins and carbohydrates, they're not able to make it from the pancreas to the small intestine. All right. And so the absence of these digestive enzymes in the intestines, they're going to lead to malabsorption. So the foods cannot be broken down and hence absorbed. Right? These nutrients are essential. They're our essential nutrients, and so these patients can become malnourished. All right. Also, because that food it kind of more or less remains in an undigested state, the stools become foul smelling. There's also fatty stools. Again, that lipase that comes from the pancreas cannot make it to the small intestine. And these patients will also experience an excessive amount of flatus or gas. Now, patients with cystic fibrosis, they secrete sweat that is high in sodium and chloride because these electrolytes are not reabsorbed as they pass through the sweat ducts. They don't get reabsorbed back into the body, right? So there is like this campaign that they call kissing something, kissing. I guess I'll run across it here shortly. But basically, they want parents to kiss the children, especially on the skin, because if you kiss someone, and they have an excessive amount of sodium chloride on the skin, then that's something that should prompt them to take the child to the doctor, because it is possible that the child may have this disorder. Because your skin shouldn't have a significant amount of sodium chloride on it. As far as cause, CF or cystic fibrosis is a genetic disorder. Both parents must be carriers of this defective gene for CF to be present in a child. Patients with CF who marry are counseled on the risk of offspring having the disease, to give them help them make a decision on whether or not they want to have offsprings. All right. Now, symptoms usually appear in infancy or childhood, although a few individuals are not diagnosed until adulthood. So it is possible to be diagnosed as an adult, but though rare. Now, respiratory symptoms are often the first visible clinical manifestation or signs or symptom of this disease, and they range from chronic sinusitis to production of a thick, tenacious sputum. Also, finger clubbing is common, and basically, the clubbing is due to chronic hypoxia. The low levels of hypoxia causes the changes in the tissues in the fingers, which makes it look clubbing, like a club, if you will. All right. Now, over time, bouts of infection become more frequent with eventual loss of lung function. The inflammation that destroys the lungs will cause the lungs to lose its normal function. And these patients are likely to develop respiratory failure as a result. Right. Now, I told you about the frequent foul smelling stools. These patients will also have poor appetite, bowel obstruction, cirrhosis, cholecystitis, and cholelithiasis. Cholecystitis is just an inflammation of the gallbladder. Cholelithiasis, the lithiasis portion of that word, meaning stones in the gallbladder, are also findings with this disease process. Now, chronic disease causes delayed in sexual maturation. So they mature sexually later, and this happens in both males and females. Infertility is also an issue with these patients. Now, death is usually the result of pulmonary complications, especially antibiotic resistant infections, because they have so many infections. At some point, they're likely going to develop an infection that antibiotics would not be very effective against. Now, diagnostic testing began with genetic testing. There's a blood test for immunoreactive trypsinogen, which may show high levels in cystic fibrosis patients. There's also a sweat chloride test that determines whether there's, as far as the sweat, someone's sweat is high in sodium and chloride. So it's called a sweat chloride test. You may also recall that there was a public campaign that advised parents to kiss their babies and report any salty taste to the healthcare provider. So that's what I was talking about earlier, the Kiss Your Baby campaign. And also there's the chest X-ray, the spirometry, and also GI tests can also help in diagnosing this issue, especially with the lack of pancreatic enzymes because the exocrine gland is adversely impacted. Some of the therapeutic um, measures. So there's no cure for cystic fibrosis, and so treatment is going to be aimed at controlling infection in these patients. Remember, the secretions are thick, they're tenacious. It's hard to expectorate those secretions, and so they remain quite a bit down there in the lungs unless we can provide medications that helps to remove them. All right. And basically, we want to try to control the symptoms for these patients. So removal of thick sputum is promoted rather by hydration. And so we want to encourage fluids. That'll make the secretions more um, less thick, right? Makes them more thin. Use of a vibratory positive expiratory pressure device, that device that essentially vibrates. Chest physiotherapy, you're basically tapping on the chest cavity. They kind of hold their hands like this. If you guys can see my hand in this video, and they just kind of just pat the patient's thoracic cavity about to loosen the secretions. They also have the high frequency chest wall oscillation vest to help break up those secretions. That's what these devices or these interventions do. Now, all forms of smoking should be avoided. Nebulized medication treatments, or your book calls them also NMTs, using normal or hypertonic saline or mucolytic medications should be considered before the chest physiotherapy intervention is performed. And the reason they use the hypertonic solutions is because when that respiratory treatment is given, it tends to draw, remember, wherever salt goes, water goes. And so you're putting this high salt content in the airways, which draws more water into the airways, and that will hopefully liquefy the secretions, thinning it, making the secretions more hydrated, if you will. So that's why they use the hypertonic solution. Of course, the mucolytics is to break up the mucus. Um, there's also an inhaled medication called homozyme, and it is an enzyme that breaks up and loosens mucus in the respiratory passageway. It is also shown to reduce lung infections and improve lung function. Because if you can loosen those secretions and expectorate them or get those secretions out of the lungs, then of course the microorganisms do not really have a place to to grow and to multiply, if you will. And so you can, with less inflammation, you preserve your lungs a whole lot better. Bronchitol is another drug that is mentioned earlier when talking about bronchiectasis. And it has been approved for use in adults with cystic fibrosis. There's also the inhaled beta agonist bronchodilators, which helps to keep the help keeps the bronchi or the airways open. There's another medication called Deco, which was approved back in 2020 for use in patients who are as young as 4 months rather, 4 months old. It is the first medication that targets the underlying cause of cystic fibrosis by improving the function of the protein that is defective in patients with cystic fibrosis. Basically, scientists have discovered that there's a protein that is missing or that is defective, and this particular drug, it more or less, you can say, replaces that protein in a way of speaking, and that's what improves the symptoms. Um, Push comes to shove, or the last resort is a lung transplant, which they indicate shows potential great promise. Also, these patients may participate in pulmonary rehabilitation programs, and that it will help to maintain their activity level. So let's continue with the therapeutic interventions. These patients, they should receive their flu vaccination yearly. Antibiotics should be also administered as soon as signs of infection does occur. Antibiotic resistant infections are a deadly threat to these patients. And so we must be vigilant in avoiding um, infections in these patients. Now, those patients who experience pancreatic issues, and of course, the exocrine gland, that tube that it connects you can say, the pancreas to the small intestine, it's destroyed, right, because of the pancreatic enzymes, and so we have to replace those enzymes, and we give these patients pancrease, Viocase, or pancrelipase. These are pancreatic enzyme replacements. All right, it takes the place of the enzymes that the pancreas is supposed to provide, and it helps reduce symptoms related to malabsorption because these enzymes that you take by mouth, they would break down the food the way it's supposed to be, and of course, malabsorption or absorption of these nutrients is improved, and so thereby improving the nutritional status of these patients. These patients, because they are at risk of nutritional deficiencies, we should increase their caloric requirements, high calorie, nutrient dense type of a diet. All right. So now we're moving on to pulmonary embolism. And I really kind of feel for you guys in a way because, we go from one disease process to another, and, it isn't really important for you to distinguish or make a distinction between each one because as you talk about them so much, it's so easy to get them all confused. So hopefully you guys are kind of keeping up with what each one of them is. All right. With the pulmonary embolism, we're just talking about a blood clot that has traveled to another part of the body. All right. So an embolism, it is a foreign object that travels through the bloodstream. It may be a blood clot. It can be air, like if you're injecting someone with the medications, or if you have an IV bag hanging. And it's you have a lot of air in the line that you didn't clear, or it can also be fat that travels from, let's say, a long bone. You have a long bone fracture, and the fat from the bone marrow is released into the bloodstream. It can be any of these. Any of these can become an embolism. It's not just blood clots. Now, pulmonary embolism is sometimes also called pulmonary thromboembolism. and it's usually a blood clot that has traveled into the pulmonary artery. And if you can take a look at figure 3111, actually, um, figure 3111, see if I can. I said I need to start showing you these things a lot more. Usually I would show you in the classroom what they look like. Let's see. All right. So as you can see, this is the pulmonary. Basically, this would be um, your lungs, right? And within the lungs, you have your bronchioles or the alveoli, if you will. But if you look at the blood vessels, which is represents this blue, that would be like your blood vessels, and this is just showing a blood clot that is clotting off one of these pulmonary, like your pulmonary artery, for example. And basically blood cannot go beyond that point, right? It gets more or less stuck right there. And this looks like a total occlusion, which is really a medical emergency. So that's what that pretty much looks like. Not the best picture that I like to see, but kind of gives you an idea. All right. Um, all right. So basically, you have this resulting, whenever the blood clot travels to the pulmonary artery, you have this resulting obstruction of blood flow. And it leads to what we refer to as ventilation perfusion mismatch. All right. Let me actually show you what that looks like because I actually pulled up something to show you. All right. Uh, Let me see if I can increase the size of this just in case you all can't see it that well. Let's see. Let me do that. All right. Well, maybe that's bigger. Oh, no, this is bigger. All right. So, uh, all right, there you go. So here's what we mean by, and I just want you to just get an idea of what we're talking about because there's a test that we can perform that can let us know what the ventilation perfusion is. We don't want mismatches. We want a ventilation perfusion match, meaning the amount of air coming in pretty much matches the amount of blood flow going through the alveoli, right? So the ventilation is the air or the oxygen part and the perfusion is when we talk about the capillaries that surrounds the alveoli. And that is what we want a certain amount of air coming in or oxygen coming in and a certain amount of blood perfusing around the alveoli. And then therefore we have a ventilation perfusion match, right? Meaning the patient becomes oxygenated very well. So here's what we mean. So as you can see here, you see this red arrow here. This is oxygen, and this is an alveoli. This is just a single one because you know they look like little grapes. But this is an alveoli. This is where oxygen and CO2 is exchanged. You see the CO2 is going out, and the oxygen is coming in. And so the oxygen is entering into an alveoli, and then it crosses the alveoli into the capillary, right? And so this is how we get oxygenated blood. So what happens sometimes is if there's just picture there being an obstruction right here. There's a blood clot right here, a pulmonary embolism. And so you're not getting blood flow beyond this point. Just watch my cursor here. You're not getting blood beyond this point. You're getting the air in, but you're not getting the blood flow. See, we want you to have blood. We want you to have good oxygen entry, right? That's crossing over into the vasculature, but we also want you to have good perfusion, right? And so when someone has a pulmonary embolism, they have the oxygen that they're receiving that's crossing the membrane, but they don't have the perfusion, and so therefore it becomes a pulmonary a ventilation rather perfusion mismatch. You got the ventilation that red, but you don't have the perfusion, and so there's a mismatch, and so these patients are going to become or their oxygen levels are going to drop. because you don't have the blood available to take the oxygen to the rest of the body. And so, just want to kind of give you a visual of that, so it would make sense to you. All right. So again, you have this mismatch. Now, in this case, it means that the area of the lung is well ventilated with air, but no blood flow or perfusion, as I just mentioned. Now, because reduced or no blood supply is available to pick up the oxygen in the affected lung, right? It is going to become like a dead space. And basically, the patient is going to have serious gas exchange problems. You're getting the air, but you don't have the perfusion. So that gas exchange is not really happening, and so this patient is in trouble. All right. Now, occasionally damage occurs to the portion of the lung because of lack of oxygen. If that part of the lung does not get oxygen, it is going to die, which we call a lung infarct. Like we call it myocardial infarction, like a heart attack, or a cerebral infarction, like with a stroke. Well, for the lungs, you also have this infarction because of a lack of oxygen. All right, it is not common because oxygen is delivered to lung tissue not only from the pulmonary arteries, but also from the bronchial arteries and the airways as well. So you don't see this as much, but it can occur, especially if it's large enough and it lasts long enough. All right, and this is what I was just showing you with the pulmonary embolism right here in the pulmonary. It's probably a pulmonary vein. All right. Now, most pulmonary emboli originate in the deep veins of the lower limbs or extremities. We call it a DVT, right? Deep vein thrombosis. Therefore, every effort should be made to avoid risk factors for DVTs. Anything that can lead to a DVT, we must minimize that risk as much as possible. Now, less common causes of a pulmonary embolism include fat emboli from a compound fracture, that fat from the bone marrow. Also, it's less common that it would result from the amniotic fluid that can also get in to the bloodstream and travel to various parts of the body during labor. And also air embolisms from air entry into the bloodstream, like a syringe with a lot of air that you didn't clear. All right. When you think about the amniotic fluid contains fetal cells, hair, the protective fetal skin covering, and other debris. And this can enter into the mother's bloodstream and travel to the heart, lungs, and so forth as well. But these are fairly rare. And like I said, the fat itself, when we talk about fat embolism, the fat comes from the bone marrow in the bones when they're broken, especially with your, what do you call it? Your compound fractures. Now, prevention of thrombi in the deep veins of the legs is the most common factor in prevention of PE. We should advise the patient to ambulate regularly and avoid prolonged periods of sitting. Because remember, the way blood continues to move is when we walk, the muscles of our lower limbs, it squeezes those veins and it pushes it back up to the heart. But if somebody's on prolonged bed rest, for example, or they're sitting for a prolonged period of time, then they're not getting that movement of blood back towards the heart as a result. So that's why we encourage walking regularly. If a patient is at risk for DVT or PE, such as following a surgery, like a femur fracture, or during times of immobility, maybe they had a stroke or something, or they were on medications, or rather anticoagulant medications may be ordered, especially after surgery or periods of immobility, like heparin or Lovenox. those drugs may be ordered in order to minimize risk. There's also a device called the intermittent pneumonic compression, or we also call them SCD, sequential control device, and that squeezes the legs as well. There's also a graduated compression devices used also. Now, compression devices use cuffs around the lower limbs that fill up with air, and it squeezes the legs. And this squeezes that blood flow back towards the heart as if you're walking, kind of mimics that. Early ambulation, leg exercises are encouraged. If a DVT is diagnosed, prompt treatment is necessary to prevent it from breaking off and traveling throughout the body. All right. The most common symptoms of a PE is, and I want you to keep note of this, is sudden onset of dyspnea. Sudden onset of dyspnea for no apparent reason. It just comes on. The patient may be gasping for breath, and they may also appear very anxious. They may also have tachycardia, tachypnea, coughing, as well as pleuritic chest pain. Pleuritic chest pain is just deep, sharp pain in the chest. You may also auscultate um, crackles or a friction rub. And that's when the pleural surface is rubbing against the parietal or the visceral and the parietal surfaces of the lungs, of the coverings of the lungs. They rub together, basically. If lung infarction does occur, you might also see hemoptysis or coughing up blood. Some patients have no symptoms at all. Um, so we must be vigilant for the presence of risk factors and obtain immediate assistance if the cause of dyspnea might be a PE. So we have to really jump on this, maybe call the rapid response team if need be. All right, because death can occur if treatment is not fast and effective. All right. That friction rub sounds like a grating sound or like a scratching sound when you auscultate the breath sounds, by the way. It's basically when the pleura, the lining of the lungs, and the peritoneum, lining of the chest wall cavity, becomes inflamed and they rub against each other. And so that's what that is. All right. Now, let's look at the different diagnostic tests that are performed to determine if someone has a pulmonary embolism. One of those tests is the D dimer. It's a D dimer blood test that can be helpful to rule out pulmonary embolism. It results can be the results of this test can be obtained in less than an hour. And basically, D dimer is a fibrin fragment that is found in the blood after any thrombus formation. So when a thrombus is formed, a blood clot forms, it is going to release this D dimer into the bloodstream, right? And so we'll be able to know if someone has um, a blood clot. It can be present in a number of disorders as well, but if it is negative, PE can be eliminated as a possible cause of the patient's symptoms. So the D dimer can be used for other tests, right? But at least if it is negative, we know that a PE may not be likely. Now, spiral CT scan, and I want you to note it is spiral CT scan, not just a regular CT scan. This is a spiral CT scan. This test is done with contrast dye. So we need to talk about allergies to this dye. It is a non-invasive procedure, but it can diagnose a PE very quickly. Right. If this is not available, we can do what is called a lung scan. Remember, we talked about the ventilation perfusion scan. Well, this is what this scan does. It detects the ventilation and perfusion. And it is done to assess the degree of ventilation of lung tissue and the areas of blood perfusion. And so it's assessing that ventilation perfusion that we talked about. If an area is well ventilated but poorly perfused, we're going to refer to this as a mismatch. Remember I said that. You may have ventilation, got that air going in and out of the alveoli, but the perfusion is poor. And so we'll call that a mismatch. And so in this case, a pulmonary embolism is suspected. The other test here is a pulmonary angiogram. It is an invasive test that can outline the pulmonary vessels with a radiopaque dye that is injected into a cardiac catheter. There's a catheter that is referred to as a cardiac catheter, and they inject this dye, and it'll give you an outline of the pulmonary blood vessels. It can show where blood flow is diminished or absent, which can suggest an embolism. Because remember that that embolus is blocking. It can block rather some of the blood vessels in the lungs. And so this test will show that there's a reduction in blood flow in that area. Chest X-ray, ECG, or EKG, ABG analysis, and MRI can also be done. But many of these show changes only in the presence of a very large embolism or infarction. And so they may not be as ideal as the lung scan or some of the other tests that I mentioned, especially the spiral CT. That's one of the big ones that is much more definitive, if you will. Take a look at the therapeutic interventions. So thrombolytic agents such as Activase and Retavase. You may also hear Alteplase and Retaplase. They may be used if the pulmonary embolism becomes a life-threatening emergency because we need to dissolve the clot. This is what the thrombolytic agents do. They dissolve the clots more immediately, as opposed to the anticoagulants. They just stop new blood clots from forming. Right. So don't get those two mixed up. Very easy to get them mixed up. Thrombolytics must be administered within 4 to 6 hours of the clot's occurrence or formation, and they are associated with the risk for hemorrhage. So these patients can bleed. No invasive procedure should be done after this medication is administered. If you're going to do any invasive procedure, it should be done before. If you need to put in a Foley catheter or, and well, you won't be doing an enema, but say if you have to do an enema, anything that you're inserting in an orifice, an NG tube, you cannot insert these devices, catheters, or venipunctures after this drug, this thrombolytic is given. Do everything before. So anticipation is very important here. Patient comes in with a pulmonary embolism and they're throwing up a lot. You may want to ask the physician, hey, do we need an NG tube? Physician says yes. All right, go ahead and put in that NG tube before the thrombolytic. Now, in patients who cannot tolerate the thrombolytic agent, the clot may be removed with a cardiac catheter. So just like you would do a heart cath, they would insert rather this catheter in the same manner, and the catheter will be inserted near the embolus, and they can inject medications to dissolve it. There's also a surgical procedure that can be done to actually remove it, and it's called a surgical embolectomy. Embolectomy. Embo is the clot. Electomy, you're basically removing the blood clot. Can be done as well. And they usually don't do the latter one, the surgical embolectomy, unless it's really, truly an emergency. Now, oxygen is also administered even if the SpO2 is normal, because the oxygen tends to help the pulmonary blood vessels dilate, and that's what we want. We want pulmonary vasodilation to get that blood around the blood clot. These patients may also require intubation and mechanical ventilation in some cases, but I can tell you when I come to class why that might be a mistake. All right. I don't want to really go into that too much now. Um, Now there's long-term use of anticoagulants that follows the initial treatment in order to prevent the formation of additional clots. And so these patients may be placed on heparin or Xarelto. Um, these patients, if they are also administered heparin, especially a heparin drip, clotting studies, the PT, PTT, the INR will be ordered because we need to know what those values are. Those values tell you if the patient is getting too little or too much of these medications. And so it just helps us, it guides our therapy or treatment. Sometimes heparin therapy is initiated even before the diagnosis of a PE is made. So even if the PE is not actually diagnosed, they may just go ahead and start them on a heparin drip because heparin drip has a really short half-life. And if the test shows that there is no blood clot, then a pulmonary embolus, then you can DC it, and the effects of that drug will wear off fairly quickly. All right. It is just believed that it's safer to begin the therapy than to stop and then stop it if the PE is ruled out, rather than waiting until all the tests are done and available, because the person may start developing more clots. And so that's what you're trying to prevent. An oral anticoagulant is also used for at least 3 to 6 months after a PE in order to prevent any reoccurrence. It also can be used for long-term prevention of repeated clots in patients who have risk factors that cannot be resolved. And so these patients may be on it a whole lot longer. Oral therapy can begin 2 to 3 days after the heparin therapy has begun. Um, so basically, what this is talking about is, so the heparin will be started. It's like an IV heparin drip, right? It's a continuous infusion, and but you can't stay on a continuous infusion for the rest of your life. Eventually, these patients need to be on an oral anticoagulant drug. So about 2 to 3 days into the heparin therapy, they will start the oral anticoagulants because the onset of action of those oral anticoagulants is much slower, and and it takes a little time to get the drug levels to a therapeutic level. Typically, maybe the INR. For example, if you prescribe Coumadin, the INR is supposed to be between 2 and 2.5, probably roughly about 2.5. And that shows that they have enough of the drug in their system at a therapeutic level that can hopefully prevent blood clots from forming. But keep in mind, even on an anticoagulant like Coumadin, blood clots still can form. And so they like the more newer anticoagulants like the Xareltos and Argachaban and some of the others. Right. So anyway, it may take a little longer for example, the Coumadin to reach that therapeutic level. So they're going to still be on a heparin drip until they reach that therapeutic level. Say if they once they reach 2.5, then they can DC the heparin drip, and then they can go home shortly after. But they typically in the hospital until they reach that therapeutic level. It's called an INR, R as in Romeo. It's just a lab test that tells us if the Coumadin is normal, therapeutic level. Now, if the clots are a recurring problem, um, there's a filter may be placed near about or into the inferior vena cava, and by way of they insert this filter, and they go in by way of the inferior vena cava. They go into the jugular or even the femoral vein. And what this device does is it's a filter. It traps the clots from traveling from the lower extremities towards the heart and the lungs, because that's where you don't want those clots. We call it typically a greenfield filter. Um, Let me see if I can show you one real quickly. Uh, it's called a greenfield uh, filter. show you what it looks like. I guess that's a good, yeah. Don't know if I can make that bigger. Uh, let's see, right here. This is a filter, and this is the clot. See how it captured that clot? It's called a Greenfield filter. Some patients they cannot go on. They cannot go on or tolerate anticoagulants, and so they put this physical device in the inferior vena cava to capture the clots instead. I want to say they last for approximately um, is it 5 years or 7 years or something like that, and then of course they have to replace them. And these are your nursing diagnosis. And we're concerned about impaired gas exchange, especially if the clot is in the pulmonary artery. You have poor perfusion, but you have good air exchange, but probably not for long. Anxiety, and also risk for bleeding related to anticoagulant therapy. This is a big one. When somebody's on an anticoagulant therapy, you need to be mindful of observing their orifice. In other words, any opening that leads into the body, like the nose and the mouth and the ears and the urinary tract and the rectum. These are areas in the body that something can, well, blood can actually um, come through those orifice or those openings and whatnot. So we're always watching those. Soft bristle toothbrush is really important. They should be shaving with an electrical razor instead of a razor. These are the things you need to be thinking about with these patients. They should avoid injuries and whatnot because just a mild injury can result in a significant amount of bleeding. Again, I'm going to say to you, a thrombolytic breaks up the clot. Anticoagulants prevents blood clots from forming. If their blood pressure is dropping because they're not getting any good perfusion throughout the lungs, we need something more immediate. Kind of like when you're thinking about the short term or the short of the SABA, right? The short-acting beta adrenergic blocker. You know what we use in acute episodes of asthma, right? We use those drugs because we need it immediately, not the long-term ones. For the immediate, but the short-term, short-acting ones. And so we need that. So in this case, rather, in terms of pulmonary embolisms, we want to break up that clot immediately. But we also want to place them on an anticoagulant about 24 hours after they receive this blood busting agent, and we want to start them on that in order to prevent any new clots from forming. And so that's something that's very important for you to remember. I promise you, it's important. You likely see it again. All right, so here we're talking about the pneumothorax, um, and you're going to see where I abbreviated pneumothorax with PTX. PTX is abbreviation we use for pneumothorax. All right. So what I want you guys to think about in this instance is that chest tube we talked about, right? And so this is the pleural space here. This is the lung, right? These are the lungs, the left and right lungs. And when the chest tube is inserted, the chest tube is inserted in the pleural space here, right? And basically, the chest tube is trying to keep this area that surrounds the lungs. It tries to keep the pressure negative because as long as and just understand this in general. Don't get too emotional about it. But anyway, so we're trying to keep this pleural space negative. All right. Naturally, our body does that. But when there's a hole in the pleural space, we lose that negative pressure. And what happens is when that negative pressure is lost, the lungs will collapse. But as long as the negative pressure is here, the lungs can expand. And you may still have a collapsed lung, but that's why we put the chest tubes in, like in the traumatic pneumothorax. We put that chest tube in this space, and waiting until this area heals, and eventually the lung will re-expand and look like this. All right, that just kind of gives you an idea of what I'm talking about. Now, the term pneumothorax, it literally means air in the chest. Pneumo is air, and thorax is chest. It is described, it is used to describe conditions in which air has entered that space between the visceral and the parietal pleurae, right? So this is what we're talking about, the parietal here and the visceral that actually covers the lungs. So there's a space here, and air is now in this space where it shouldn't be. Air is supposed to be in the lungs, not this space. All right. Now, if the pneumothorax occurs without an associated injury, like if there's no injury that causes it, then they refer to it as spontaneous pneumothorax. All right. The lungs just collapsed, and that can happen. Um, a secondary pneumothorax may occur due to underlying disease. All right. And what we mean by that is sometimes there are diseases like emphysema that causes a weak structure in the lung tissue. And it can cause the lungs to collapse. All right. Now, a traumatic pneumothorax results from a penetrating chest injury, all right, like a knife or gunshot wound. And then, of course, you have the iatrogenic a type of pneumothorax, and that is caused by medical treatment. So, for example, if somebody is putting in an IV line, which we call a central line, into the chest cavity, right? They can actually puncture the lung, the pleural space and the lungs and whatnot can be pierced. If they're trying to get a pleural biopsy, they're trying to basically get a biopsy of this area where you see my cursor moving, right? That can also result in a pneumothorax and an injury. Another thing that can result in a pneumothorax is if somebody's on a ventilator. See, in a ventilator, you're forcing all that air into the trachea and also into the lungs. If that pressure is too much, and it doesn't, well, it can be pretty high pressure, right? I don't want to get too much into that, but sometimes there's high pressure we're delivering into the lungs. And if the lung tissue is compromised, if it's weak, it can actually blow out, a rupture of the lung tissue. So that's another reason. So think about the pressure from the ventilator. All right. Now, as far as the pathophysiology and cause, we kind of went over some of the causes. But what I want you to do is I want you to recall that the lungs are surrounded by the visceral and the parietal pleurae. And just think about anything that is within this area is considered the visceral and parietal pleurae. Now, these membranes, they're called membranes, are normally separated only by a thin layer of pleural fluid. See, you got the parietal and the visceral structures, but there's a thin layer of pleural fluid, and what that does is when the lungs expand, they slide, right? They slide over the parietal tissue. Right. As long as you have that pleural fluid there, they're going to slide and be more slippery, as opposed to when inflammation is here, then the parietal layer and the visceral layer, they rub together. And that's when you get that pleural friction rub that I was talking about, that grating kind of sound. You'll hear that. But there's fluid that we call pleural fluid. Now, each time a breath is taken, right, when someone breathes, the diaphragm, it descends, it flattens out. Now, this creates what is called this negative pressure in the thorax. The thorax. Remember, I told you about the negative pressure, which is why we use a chest tube with these injuries in order to recreate that negative pressure. That negative pressure keeps the lungs inflated. Just remember that in general terms. Now, this negative pressure pulls air. This is why this negative pressure is important. It pulls air into the lungs by way of the nose and the mouth. You know, we inhale. And so this negative pressure is what pulls it in. If either the pleural, the visceral pleural or the chest wall and the parietal pleural are perforated, then air is going to enter the pleural space. So, for example, here you got this piercing, and air is going to enter into this space, right? Because it's perforated. Air is going to enter to the space, and that negative pressure that I was telling you about, that is usually here, is going to be lost. And the lungs on this, like the affected side here, is going to collapse, as you see here. See, you got this penetrating injury here, and that negative pressure that is normally there, it would typically keep the lungs open. But since it was pierced, this injury here, you lose the negative pressure, and then the lungs collapse. So they're going to actually insert a chest tube, and over time, this pleural tissue is going to heal, and of course the negative pressure is going to be reestablished here, and then the lungs will expand to look like this again, hopefully, hopefully. So just want to give you a visual of that. So each time the patient takes a breath, the resulting increase in negative pressure will draw more air into the pleural space via the perforation. And so this is not what we want. The perforation just takes away that negative pressure. All right. During exhalation, air may or may not be able to escape through the perforation. So sometimes the air remains in. If it escapes through the perforation, air will go in, but it'll go out, but also comes in. But there are times where the air builds up in here. All right. If that air builds up in the pleural space, a lot of it builds up. You see how the trachea is straight here, and these structures, the heart and everything, is all intact. If someone develops a tension pneumothorax, meaning a lot of pressure is in this side of the lung, it is going to start to push on the good side. So the affected side, where all that air is located and building up, will start pushing on the good side. And you see how now the trachea is deviated, right? And those mediastinal structures, that's just a part where the heart and the great vessels are located. It will push it over to the unaffected side. We call that a mediastinal shift. And that's a medical emergency there for sure, because, well, this patient is really going to need that chest tube, because that blood that is returning to the right side of the heart, it's not going to be able to get through the vasculature, because you got all that pressure that's pushing on the heart and those great blood vessels. And so these patients go into basically shock, because remember, blood flow can get up here, but it can't go through the vascular structures in the heart and lungs, right? Right? To ultimately be pushed out into the systemic circulation. All right. Um, all right. All right. So I get you guys to read the rest of this. I just want to give you a visual of it, because it can take a lot longer if I go through each one of these. Kind of just describing the different types of pneumothorax again. All right. So signs and symptoms: there's sudden dyspnea or shortness of breath. There's chest pain, tachypnea or rapid respiratory rate. There's also tachycardia or increased heart rate. Restlessness and anxiety occur with a pneumothorax. Now, on examination, you're going to have this kind of when you're inspecting or looking at the chest wall. Remember, when you're looking at the chest wall, normally in normal individuals, both left and right chest wall should rise and fall at the same time. That's symmetrical. But if someone has a blown out lung, let's say on the left side of the chest wall, then you'll see the right side, the right lung expand the chest, but the left side will drop. All right. And so we refer to that as asymmetrical chest expansion on inhalation. Because remember, when you inhale, both chest walls, left and right, they rise together. If you got um, uh, a pneumothorax, only the right side is going to move if the left side is if there's pneumothorax. Also, when you auscultate breath sounds, let's say if it is a left-sided pneumothorax, then you won't hear breath sounds on that side. Or they will be diminished on the affected side where the collapse is located. Now, also in a sucking chest wound, like if someone has maybe a stab wound, air can be heard as it enters and leaves the wound. So, if you were to put your ear near the wound, you will hear that air going in and out. We call that a sucking chest wound. Take a look at the signs and symptoms of a tension pneumothorax. If a tension pneumothorax develops, these patients are going to become very hypoxemic, right? And also hypotensive, because remember that blood that is returning from the right side of the heart won't be able to get through that vasculature, the blood vessels of the heart and the lungs, because everything is being pushed over and compressed. And of course, if blood cannot get back over to the left side of the heart, then you're not going to get much blood out into the systemic circulation. And therefore, these patients will experience shock. The trachea is typically deviated to the unaffected side. I showed you that. Also, because of all that pressure on the heart is not able to expand like it should. When it squeezes and relaxes, it won't be able to do that. So when you listen to the heart sounds, they sound muffled. Bradycardia is going to occur, or low heart rate is going to occur because your cardiac output is just so low. And shock will follow as well. This is an emergency situation, and so something has to be done. All right. Um, yeah, and if I didn't mention cyanosis, I mean that's for obvious reasons. Not getting any oxygen. All right. Some of the diagnostic tests. This condition is diagnosed by history and physical examination. An ultrasound can also be done at the bedside, which will give you a quick diagnosis. Chest X-ray and CT scan can also be used. It may take a little more time, so the bedside ultrasound will be more desirable. All right. And so now a chest X-ray is done almost pretty much daily when a person has a chest tube. They're done pretty much daily to see if the lung has re-expanded. All right. While the patient has that chest tube, we're monitoring the chest X-ray to see if the lung has expanded. These patients may also require ABGs or arterial blood gases to look at their acid-base balance, hopefully, and also the O2 saturation to see if they're oxygenating well. All right. Let's see. Um, we also need to monitor. Well, I talked about it, monitoring the ABGs. We also want to monitor the patient's respiratory status. If the chest tube is inserted to water seal drainage, this will help to maintain that negative pressure that we lost. So we have to monitor the chest tube and the information that we went over the other day. Remember, the chest tube removes air as well as blood. If it's a pneumothorax, then it's we're moving air. If it's a hemothorax, we're removing blood. But it can be a hemo or pneumohemo. I think it's hemo thorax. It can be both, and so the chest tube will remove both. So both would be possible. Um, let's see. There's also a procedure called pleurodesis or sclerosis, wherein if a patient has a recurrent pneumothorax, there's this substance called talc, sterile talc or tetracycline that they inject into the pleural space, and it'll basically form like this layer over the pleural. Um, Site where you have uh, the 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 puncture of the pleural tissue, and it'll cover that area over, or makes the pleural membrane stick together, and it pretty much resolves the pneumothorax. This procedure can be pretty painful, though, so give this patient some pain medications, of course, before it is started. Um, um, this medication is also injected via what we call a thoracentesis. This is when they can inject or remove substances from the pleural space, but it's called a thoracentesis. Think about the what is it, the paracentesis, which is removing fluids from the belly. Well, this thoracentesis, you can remove fluids from the thoracic space as well. All right. It basically irritates the pleural membranes and causes them to stick together. And so basically healing that site. It forms like a scar over the pleura tissue where the injury is located. Um, let's see. These are monitor. All right, so monitor respiratory status, as I said, monitor the chest drainage, especially if it's too much. That needs to be reported to the physician as soon as possible. Frequent and thorough assessments should be performed. We want to look at the level of consciousness, skin and mucous membranes, color, vital signs of the oxygen saturation, the respiratory rate and depth, the presence of shortness of breath or chest pain, restlessness, as well as anxiety. This should be a part of your assessment. Remember, if these patients are not oxygenating well, the level of consciousness is going to be compromised. We also have to regularly auscultate the breath sounds to hopefully what to make sure that the lung has re-expanded. Because once the lungs are re-expanded, as we have the chest tube in, then it would be time to remove that chest tube shortly thereafter. Now, we also have to be vigilant for signs of increasing or tension pneumothorax. Remember, with the tension pneumothorax, all that pressure is building up on the affected side and is pushing everything over. The physician needs to be notified immediately. Now, some of the appropriate nursing diagnosis, you have your impaired gas exchange, your acute pain, as well as your anxiety, as well as dealing with anxiety. All right. And now we turn to rib fractures. Right. So chest trauma is often accompanied by fractures of the rib. Say if somebody's in a car accident and their chest wall hits the steering wheel, or somebody may, hit them with a baseball bat. It is going to fracture the ribs. These patients typically, it can also be caused by uncontrolled coughing, especially if the bones are already weak, let's say due to osteoporosis, or maybe the patient has metastatic bone cancer that has spread to the ribs. If they cough forcibly enough, it can also crack their ribs. Patients who fall more frequently, like like the elderly, or this is a common problem, broken ribs with them as well. The fourth through the ninth ribs are the most commonly affected areas. Fractured ribs can be very painful, and they're so painful. And remember, the ribs are around the area where we breathe, and so if it's so painful, these patients are taking more shallow breaths as opposed to deep breaths, and they will not want to cough either. All right, and of course. When we're not breathing and coughing like we should, this is going to result in what is referred to as atelectasis. In other words, the alveoli collapse. All right. Or the patient may develop pneumonia because they're not mobilizing those secretions in the lower airway. All right. Now, displaced ribs can also damage abdominal organs, lung tissue, and it can lead to a pneumothorax. All right. Because those bones become pretty sharp. In terms of therapeutic measures, now they used to use an elastic rib belt, but they don't use those much anymore because it restricts breathing. All right. The most important treatment is pain control because if the pain is under control, then patients will breathe, they'll cough, and so forth. All right. They'll cough and deep breathe. And this can, of course, reduce or prevent complications of pneumonia as well as atelectasis. Now, if traditional pain control measures such as NSAIDs or opioids are not effective, sometimes they will do an intercostal nerve block. So the nerve that innervates or stimulates the rib muscles um, will be blocked with a drug, and of course that would decrease that pain signal to that area, to the rib area. It takes about 6 weeks for the ribs to heal, by the way. Oh, by the way, as far as etiology, you saw this. It can be done, or the rib fractures can occur due to CPR. Sometimes the CPR is a bit much. There are times, of course, when patient may be elderly and the bones are already maybe brittle or weak, and so forth and so don't take really that much. All right. Now, let's talk about or turn our attention to what we refer to as flail chests. Flail chests. And this is basically when multiple ribs are fractured. All right. The structural support of the chest is now impaired. Remember, the ribs give structure, but when several of them are cracked or fractured, we lose that support. All right. Now, as a result, the affected part of the chest it collapses. So if the right ribs ribs are fractured, the chest it collapses basically with the negative pressure of inhalation, and it bulges with the exhalation. Right. So here's what I mean by that. So usually when we inhale, our our chest wall bulges or it expands outward. When we exhale, it pushes inward. And so when someone has a flail chest injury, the opposite occurs, right? And so when someone inhales, the chest actually bulges out. And when they exhale, it goes in, or rather out, right? Right? Because when you exhale, um, it is supposed to go out. I'm sorry, no, I have to kind of do this myself. So when you inhale, it expands. When you exhale, it pushes inward your chest wall. But with flail chest, the opposite occurs. So just remember that. All right. And we refer to this as paradoxical respiration. Remember that term, paradoxical respiration. All right. Which may be ineffective in ventilating. When this occurs, it may be ineffective in ventilating the lungs, and it can result in hypoxia. All right. So the patient with flail chest exhibits chest movement that is opposite to that usually seen with respirations, basically. And the patient also becomes short of breath, anxious, and they may also become tachypnic, meaning they breathing really fast, and also tachycardic, increased heart rate. The treatment protocol involves supplemental oxygen. So place these patients on oxygen. Make sure you medicate them for pain. These patients may require intubation, but it is typically avoided if possible because of the related risk of infection. If the lung damage has occurred, treatment for pneumothorax may be warranted, and so the patient may require um, what is it, a chest tube. Also, surgical stabilization of the ribs may also be done in some cases. All right. Take a look at your nursing diagnosis, and of course, now we turn our attention to acute respiratory failure. Acute respiratory failure. Now we're dealing. Well, always been dealing with the lungs, but um, all right. So acute respiratory failure is diagnosed when a patient is unable to maintain adequate blood gas values, right? They're not able to maintain that pH of 7.35 to 7.45 or that PCO2 of 35 to 45 or the bicarb between 22 and 26 or the oxygen levels of at least 80%. If they're not able to do these things, not normally because of respiratory failure, then these values are going to be off. Now, hypoxemia, remember that the decreased amount of oxygen in the blood may result from inadequate ventilation, right? So when we talk about ventilation, we're talking about air that is moving in and out of the lung, inspiration, expiration. That's the ventilation part. But then we also talk about oxygenation. And these patients would typically have poor oxygenation. Oxygenation is when gas exchange takes place at the alveolar capillary membrane level. So the ability to exchange oxygen and carbon dioxide, that's oxygenation. Ventilation is when you're not bringing in enough air, right? Your inspiration expiration is off. All right. It can be both in these patients. They can have both um, inadequate ventilation as well as poor oxygenation. All right. Now, something we call hypercapnia. The hyper is high and capnia is CO2. So these patients experience hypercapnia because they're not able to either sometimes their ventilation is inadequate and they have poor gas exchange, and so the CO2 is going to increase in their blood, and so we call it hypercapnia. And if you have hypercapnia or increased amount of CO2 in the blood, then we have a patient who is in respiratory acidosis, right? Because of increased CO2. So when an ABG is done, it is going to reveal a respiratory acidosis. It is think about Rome, respiratory opposite, right? In this case, the pH is down, the arrow points down, and the CO2 is up. When I say CO2 is up, I mean there's an increased amount of CO2, hypercapnia in the blood. And this occurs when the diseased lungs are not able to fully eliminate carbon dioxide. Now, as far as a cause, an acute respiratory infection in a patient with chronic obstructive disease, COPD, is often the precipitating factor in acute respiratory failure. This is what happens first, an infection of the lungs. Now, other causes might be central nervous system disorders that affect the muscles of breathing, such as a stroke. You know, some people they stop breathing, or they don't breathe as well. There can also be a spinal cord injury. You know, the spinal cord also helps control breathing. You know, the nerves, myasthenia gravis. All right. Also, inhalation of toxic substances that can damage the lung tissue, which would impair that gas exchange. Opioid overdose, and that, of course, will initially affect your ventilation because it will suppress your respirations, and so you're not getting you're not ventilating the lungs adequately, right? Because you're suppressing respirations and also aspiration. You aspirate something into the lungs, fluid into the lungs, and that is going to affect your gas exchange, right? Because you got that fluid down in the alveoli capillary membrane area of the lungs. And so gas exchange is going to be compromised. Remember, poor oxygenation due to decreasing gas exchange is one of the causes of acute respiratory failure. Take a look at the signs and symptoms. The ABGs will look pretty bad. You have increased dyspnea, right? Because the patient is not getting enough oxygen, restlessness and confusion. Think about you're not getting oxygen to the brain. And so lethargy, you're not getting, again, enough oxygen to the brain, and coma and death. All right. They become agitated, they become sleepy. Um, the ABG is going to show a low PO2 of oxygen levels. The pH and pH. The oxygen will be low, the pH will be low, but the PCO2, the carbon dioxide, is going to be high. So that'll lead to your respiratory acidosis, as I mentioned. These patients also become cyanotic, short of breath. Their respirations become rapid and deep, as in Kussmaul respirations, in an attempt to blow off the CO2. But they're usually unsuccessful if we don't turn this around. All right. Now, respiratory failure is diagnosed when the ABG oxygen levels fall below 60. Remember, it should be between 80 and 100, but if it falls below 60, or the PCO2 levels, which is the carbon dioxide, is above 50. Remember, the normal range is between 35 and 45. But now, if it's above 50, that can point to respiratory failure. Now, some patients with chronic respiratory disease have adapted to this impaired gas exchange. Take someone with severe bronchitis, emphysema, one of those COPD conditions. Their body actually have adjusted to the fact that they have poor gas exchange. Over time, they've adjusted to it. All right. So in these patients, a drop in the oxygen, about 10 to 15 millimeters, is considered acute failure. All right. So let's say if these patients are, if maybe they have an 80, let's say maybe a 90, right, PO2 of a 90. If it drops, which they probably won't, but just an example, if it drops 10 to 15 millimeters of mercury, how we measure the oxygen in the blood, that can be acute failure for them. All right. All right. So with these patients, we used to. All right. Let me not say that. That's kind of dealing with something else. So sputum cultures, chest X-rays will be ordered to identify the underlying cause of the respiratory problem. Additional tests may be done to determine a non-pulmonary or non-respiratory cause. It could be sepsis that may have caused this problem, and of course, these tests will hopefully help to guide the treatment, what the patient needs. Pulse oximetry would be used to continuously monitor the patient's oxygenation level. Um, these patients are typically cared for in an ICU, where they can have more frequent monitoring. And they may also use this device called a capnography device. It just measures the amount of CO2 these patients are expelling or exhaling. I think I showed you all what that looked like when I was in class. So carefully observe the patient and report significant findings to the physician. It is easy to mistake treatment treating symptoms of, say if your patient has agitation and confusion, and you want to give them a sedative, right? A sedative to calm them down. But what if the cause of the confusion is due to hypoxia because of acute respiratory failure? And you give these patients a sedative, which is a CNS depressant, you can suppress the respirations even more, which will also worsen the agitation and confusion. So we need to know why the patient is agitated or confused. All right. Um, Yeah, so basically, it would cause the patient to become worse. Now, oxygen therapy via nasal cannula or mask is also provided. If a greater percentage of oxygen is required, a nasal cannula won't touch it very much. If they need 100%, 80% FiO2, that's basically oxygen from a device, then a nasal cannula will not do it, and they need a mask, probably a non-rebreather mask. Right. Now, in these patients, the oxygen saturation or the SpO2, we should maintain it between 88% and 92%. I know that's low, but in these patients with especially a chronic lung disease, 88% to 92% is good. Right. Now, higher levels, um, uh, if we try to raise the oxygen levels too much, it could depress their stimulus to breathe because these patients, this is what I was getting ready to try to say earlier, but they depend on a higher level of CO2, right? And I know that's weird, but some patients, because their body has adapted, because they got this chronic lung condition, it has adapted to higher CO2 levels. The brain uses that CO2 level to make you breathe, right? And if you give them too much oxygen and you lower that CO2 level, then the brain won't have that stimulus to make the body breathe. That may be a little confusing what I just said, but basically they do not want to reduce the patient's drive or stimulus to breathe, and so you want to maintain the oxygen at a lower level. In other words, it's just trying to basically tell you don't give too much oxygen. We can maintain them between 88 and 92%. That's fine. Leave them right there. Otherwise, they'll stop breathing on you once you take away that stimulus. Also, check to see if, let me back up. Correct the underlying cause. Is it pneumonia? Is it pulmonary edema from heart failure? What is it? We got to fix that, right? And intubation, ventilation may be warranted. And also check for advanced directives because the patient may not want to be intubated. Right, so make sure you check that. Bronchodilators, of course, keep the airways open. Let's see. So we just looked at acute respiratory failure. So now let us look at acute respiratory distress syndrome, or what we also call ARDS. This is different. Here's what I want you to think about with this. So we talked about acute respiratory failure, the PO2, the PCO2, and whether it's that oxygenation versus ventilation and so forth. But basically, when we talk about R's, and this can get really complex. But what I want you to see here is that, all right, think about um, think about heart failure. Think about heart failure and pulmonary edema. So here's what happens when someone has heart failure: the blood is not propelled forward. Remember, blood is supposed to go forward, right? It comes back to the pulmonary vein, to the left atrium, left ventricle, and then out into the aorta, right? But in heart failure, that blood backs up. It goes the opposite direction from where it came from. And so too much blood gets into the pulmonary artery, and that fluid or that That serum part of the blood is going to seep into our alveoli, and that's what causes the pulmonary edema. All right, you got that fluid that is building up in the alveoli and the capillary membrane. All right, so that's cardiac related, right? That's cardiac related. That happened because of a poor pumping heart. Now, hear me now. So, with ARDS, what happens is because of some inflammatory situation, like somebody might have sepsis, right? And you have this general inflammatory process that affects the whole body, right? We actually call it SIRS, systemic inflammatory response syndrome. So just think about the fact that the whole body is going through this inflammatory situation, maybe because of an infection, right? And so the lungs are very sensitive to to this inflammatory response. And so the inflammatory system or the immune system actually attacks the lungs, and it brings about this pulmonary edema. But it's due to the inflammation from the immune system, not cardiac. And that's the difference when you think about ARDS. And when you think about the AC membrane or the alveoli capillary membrane, right? Let me show you what that looks like. What happens is you get all that fluid between this area, right? And when you have a lot of fluid between the alveolar capillary membrane, it's very difficult for oxygen and CO2 to exchange places, because now this CO2 and oxygen has to cross fluids. See, see, when you think about like chemistry, for example, they talk about diffusion. This oxygen is supposed to diffuse across this membrane, and the CO2 is supposed to infuse across this membrane back into the alveoli and exhale, right? So with pulmonary edema, whether it's cardiac or from the maybe sepsis or what have you, this fluid is going to build up here, right? And that's what happens in ARDS. Let's say from sepsis, all this fluid builds up and you can barely get oxygen and CO2 to exchange places. And so no matter how much oxygen we place these patients on, we can have them on 100% oxygen and their SpO2 levels will be like 70%. All right, you hear me what I'm saying? They can be on a ventilator at 100% oxygen concentration. And because of all this fluid, they cannot exchange oxygen and CO2 very well. So we call that refractory hypoxemia. They remain in hypoxemia no matter how much oxygen you give them, right? They call it refractory hypoxemia. Remember that just in case. All right. Um, All right. So acute respiratory distress syndrome, it is a group of disorders that has diverse causes, but similar pathophysiology, symptoms, and also treatment. We'll somewhat treat it just like we do ARDS, but it's a lot more serious rather. Now, ARDS can occur because of acute lung injury, most commonly from widespread sepsis. That's what I was telling you, right? That inflammation that is caused or activated by the immune system is what destroys that lung tissue, because the lung tissue is very sensitive to that inflammation. All right. So the alveoli capillary membrane is going to be damaged because of the inflammation. And pulmonary edema is going to occur. That's why I was telling you about that fluid and in between that space. There's also going to be alveolar collapse. So atelectasis. The alveoli, those little grape looking structures, they're going to collapse. And then what happens is the lungs are usually very flexible, right? But when the lungs are attacked and inflamed and what have you, when they're damaged, the lungs become more stiff and they're not as flexible. And so even though you're trying to oxygenate them with a ventilator, the lungs are just too stiff and they're damaged. And this may also cause the lungs to hemorrhage. So you may have bleeding, and so you might see hemoptysis in these patients. And so that's kind of giving you an overview of what is actually happening without going into it too much. All right. Now, other causes include pneumonia. It can be trauma, shock, narcotic overdose, inhalation of irritants or chemicals. Burns can lead to ARDS, pancreatitis, as well as aspiration of maybe some chemical or something of some sort. Um, Now, each of these causes begins a chain of events that leads to this damaging of the alveolar capillary tissue. All right. And then this is when this non cardiac pulmonary edema is going to occur. And usually these patients, they have not had a history of pulmonary disease, but now because of, that whatever the health issue is, it leads to this ARDS. Now, these patients, their respiratory muscles become very tired. Um, and because of this edema, initially when their breathing is going to be pretty fast, and so they're going to be, and you need to listen to this, respiratory alkalosis initially, but they're going to tire. That edema is going to cause them to tire, all right, the pulmonary edema. And the atelectasis is going to make it difficult for that gas exchange to take place. All right. And so these patients are going to develop hypoxia. And as the condition progresses, atelectasis and the edema is going to get worse. The lungs are going to bleed. And the chest X-ray, if you look at a chest X-ray, instead of having all that darkness in the chest X-ray, it's going to appear like it's snow inside of someone's chest cavity. It's all whited out. All right. These patients experience dyspnea, expiratory, elevated respiratory rate. That's what I was telling you. So they're hyperventilating pretty much. And so they'll be in alkalosis. You auscultate the breath sounds because of the fluid in the lungs. You'll hear fine crackles. They will eventually become acidotic once they tire out and not able to compensate anymore. Restlessness and confusion because you're not oxygenating. You're not getting any blood to the brain, and also the death rate is usually about 40%. That's pretty high. That means that almost half these patients are going to die, right? About half of them. Um, all right. Um, all right. ABGs will be done to see how well the patient is oxygenating. Chest X-rays to see, hopefully, it's resolving. A CT scan is a little more delicate, of course, can give you a little more. The ECG or electrocardiogram, just in case some cardiac issues are occurring, and other tests may be done to determine what's happening, maybe checking for sepsis and what have you. These patients need loss of oxygen, at least 100%, what we call FiO2, or fractured inspired oxygen, basically the amount of oxygen that they're receiving, usually about 100%. But we don't leave them at 100% very long. Hopefully, we can bring that oxygen level down over a period of days because too much oxygen is toxic. These patients need to be intubated and placed on a mechanical ventilator. We want to treat, of course, the underlying cause and supportive care with treating symptoms. Um, if these patients, if the urine output becomes diminished, especially if you give them, if you give them diuretics, sometimes you can deplete them, their vascular, their volume status, and so may have to give IV fluids to improve their blood pressure as well as their urine output. right? Sometimes with that pulmonary edema, though, they may give those patients a diuretic to try to move that fluid out of the body because the more fluids the body has, the more it's going into your lungs. So they'll try to give a diuretic to minimize that. These patients, they also need nutritional support. So it's preferable to feed them through the enteral route of the feeding tube. They also typically have high blood glucose levels, and so they are on AccuChecks every hour, and you're checking their blood glucose every hour. They may also insert what we call a pulmonary artery catheter. So we won't get into that, but basically it helps guide their treatment. If an infection or sepsis is the cause, or if it develops, antibiotics would be likely necessary. Let's see. Also, we like to put the patient in a position where the good lung, you lay them on the good lung side and put the bad lung up, but the good lung down. You're putting the good lung in a dependent position, and that will allow more lung tissue, a surface area, to be oxygenated. So we want to lay them on their right side, or on the affected side, the unaffected side, excuse me. Um, so the good lung is down, in other words. And also, we like to put these patients in a prone position, right? Not supine, but prone position. That also helps increase oxygenation by allowing more surface area of the lungs to occur. Take a look at the nursing diagnosis here, very appropriate, and read your textbook regarding those. All right, so now we're looking at lung cancer. Typically, I just say cancer is cancer is cancer. So usually it is due to smoking. Men and women are pretty much equally affected, but women are becoming increasingly affected by it because they're smoking more. Here's the different types. You have your small cell lung cancer, your large cell carcinoma, adenocarcinoma. Adenocarcinoma is not usually due to smoking, though. Squamous cell carcinoma as well. The only one that's not usually due to smoking is the adenocarcinoma. Everything else is. The earlier the detection, the better the outcome, of course. And I'll leave it to you to read the rest of this information. But typically, you guys know with cancer, um, you know, uh, chemotherapy, radiation, maybe hormonal therapy, and possibly surgery. They may have to remove parts of the lung tissue. All right. Remember, if someone has lung cancer, it can metastasize to other areas of the body. Right. So tobacco does cause about 80 to 90% of a lung cancer. So that's a lot. It is the chemicals in the cigarettes that causes the DNA in our cells to mutate and create changes in our cells. And of course, tumors can develop. If people stop smoking, it does decrease their risk of lung cancer significantly. Um, but there is still about 14% of adults in the U.S. that smokes. That's not as high as I thought it was. Also, we have to be concerned about secondhand smoking. This accounts for about 20 to 30% of lung cancer. This secondhand smoke is um, can be pretty significant. It may be related to or secondhand smoke may be related to breast cancer, nose and throat cancer. If you around people who smoke, can lead to leukemia, lymphoma, also brain tumors in children. Other factors that contribute to an increase in lung cancer risk are exposure to asbestos, which they don't use as much anymore, but you still may be able to find that material in older buildings, radon, arsenic, air pollution, diesel exhaust from vehicles, and also radiation. Genetic predisposition, and also poor diet low in fruits and vegetables are also factors. I must be improving because I didn't have to do that too much. All right. So signs and symptoms, none until late. Usually people don't know until it's late, but they might have a productive cough, right? Hemoptysis. There's also recurrent infection in these patients. They're short of breath. I mentioned hemoptysis. They also experience anorexia and weight loss as a result. They may also experience pain, wheezing, as well as stridor breath sounds. All right. And the wheezing, of course, and the stridor comes from when the airways become obstructed by the tumors. Right? And the respiratory infections are due to this production of thick, purulent sputum. All right. So some of the complications from this disease is a pleural effusion, and this is basically fluid that is seen in the pleural space in the lungs, and so it just collects and gets larger, and it can compress on lung tissue. Also, what we call superior vena cava syndrome, and basically what this is. Um, the tumor actually puts pressure on the superior vena cava. Y'all know the superior vena cava is where blood returns to the heart from the upper part of the body. And so if the tumor compresses it, it can interrupt the blood flow, and this can cause distension of the jugular vein. It can cause swelling in the chest, the face, as well as the neck because that blood is not draining properly. Sometimes diuretics are given to these patients to help relieve some of the fluid buildup, and radiation may be used to shrink that obstruction, that shrink the tumor. Another weird thing about lung cancer is that these cancers can produce ectopic hormones. You know, the pituitary the what is it? The posterior pituitary gland is supposed to produce the stimulating hormone, the ADH. And also the anterior is supposed to produce the ACH or the adrenocorticotropic hormone, right? But these cancers can produce hormones that mimics these types of hormones, the SIADH and the ACTH. And this can lead to like your Cushing syndrome because you got too much steroids on board and your ADH. It can cause fluid retention, if you will. But it's because the cancer cells are able to produce these hormones that can act just like these hormones that are produced in the pituitary gland. Really weird, isn't it? Also, we have to be concerned about metastasis. I think I listed some of the areas where metastasis occurs. Well, when the lung cancer develops, metastasis typically occurs in the brain, the bones, the opposite lung. So if the right lung is affected, it can go into the left lung, the liver, adrenal gland, as well as the lymph nodes. Those are the usual areas. A chest X-ray, CT scan may be ordered to determine if there's a tumor there. Sputum analysis, they'll look at analyze the sputum to see if there are cancer cells. Biopsy, that's more definitive. They can tell if the cells are cancerous. Additional tests to find metastasis, like a PET scan, can determine if there's metastasis in other parts of the body. Right. And that's what lung cancer looks like. Um, as far as therapeutic interventions, before treating the cancer, we must stage it first. We must know what stage a person is in. And so these tumors are staged based on the tumor node metastasis staging system. So as you can see here, T, N, M. tumor node metastasis. All right. This helps us to know what type of treatment the patient is supposed to have. The patient may need a combination of chemotherapy, radiation. They may have to have, and I'll show you on the next page, certain parts of their lungs removed. I would at least know what each of them mean, and I'll show you what it looks like on the next page. Let's see if I missed something out. All right, so let me show you what this looks like. Oh, right here, it talks about chemo and radiation. It talks about usually palliative, meaning we know we're not going to cure the cancer, but the radiation and the chemo can shrink the tumor, which can give the patient some relief. And so so we're looking at palliative care in this case. Now, sometimes surgical intervention is warranted. They may do a wedge resection where they move a small portion of this lobe. They may also do a segmental resection. This is just a larger portion of the lobe. They may also need to remove an entire lobe. Right here, this is must be on the right side. Yeah, the right side, because you got three lobes. So you may have to move the superior lobe, called a lobectomy. And then you have your pneumonectomy, meaning they will have to remove the entire lobe. This is the cancer here, right? That's the cancer there. But the pneumonectomy, if you listen to the breath sounds on the right side, you wouldn't hear anything because there's no lobes. Here, of course, you have to listen to the middle and the inferior lobe, and here you can pretty much listen to the entire lobe on the right side. Take a look at the nursing diagnosis when you get a chance. And this is what I just went over some of this: the pneumonectomy, the lobectomy, resection, could be segmental, and what have you. The video assisted thoracoscopic surgery. This is just like when we do laparoscopic procedures. You cut like a few incisions and go in and perform the surgical procedure. And basically, the idea is not to have to cut the patient all the way open, which means if you have to cut them all the way open, it just takes a whole lot longer for the patient to heal. And so if we can just cut like three small incisions and go in there and make these repairs or incisions and what have you, healing is a whole lot more quicker, if you will. Pneumonectomy. So I'm going to have you guys read. Oh, keep in mind too, chest tube, if someone has a pneumonectomy, meaning the entire lung is removed on either side, they won't have a chest tube. The other two, the lobectomy or the resection, they may have a chest tube. All right. Let's see, resection, video cyst. Uh, And these patients, so lung transplantation can benefit patients with a variety of serious pulmonary disorders. They may have pulmonary hypertension, emphysema, cystic fibrosis, or bronchiectasis. Now, either a single lung or both lungs or heart and lungs have been successfully transplanted. Sometimes they have to transplant both a heart and lungs. Right. Because if you have lung issues, more than likely the heart is going to become damaged at some point. Or if you have heart issues, then these patients may end up with lung issues. And so it requires both lung and heart transplant. All right. Uh, let's take a look at the pre-op care. We want to monitor the patient's respiratory status. We want to do lots of teaching. Lots of teaching can decrease the anxiety of these patients. So you have your routine pre-op teaching, what to expect. Even visit the surgical intensive care unit where they're going to be located, both them and the family, include the family because they can be very helpful at the bedside for you. You have to let them know that they may be intubated, that they may have chest tubes and IV fluids and cardiac monitoring devices. They may have Foley catheters and even an epidural catheter for pain. And so we just have to really let them know that of what to expect. We also want to let them know that in case if they, because some patients may feel a bit anxious if they can't. Communicate. And so we have to talk about ways to help them communicate, leaving the call line in place, using picture boards, using other alternative communication techniques to help them to communicate with the staff. Right. We also want to advise the patient that position changes and early ambulation can help prevent complications following surgery, especially those DVTs and embolisms, pulmonary embolisms, and the like, the intestinal obstructions or ileuses and so forth. Also, we want to instruct them proper use of the incentive spirometer and turning, coughing, deep breathing techniques. Um, especially after the ET tube is removed, that endotracheal tube is removed. You want to teach them all these things because we don't want, pneumonia to develop and other respiratory complications. All right, folks, we're getting pretty close. All right, so post-operatively, we're going to have these patients likely in an ICU. We're monitoring their vitals, the SpO2 levels, the ABGs. They're on a ventilator. Remember that. We want to make sure they are, the ABGs look well. They may have these hemodynamic devices like what we call a swan gas catheter, but don't you worry about that. Lung sounds, we're auscultating lung sounds to make sure that patients are doing well. The patient may be on the ventilators and they may have chest tubes as well. And so, again, all that's a part of the pre-op teaching. Um, Now, an increase in pulse rate or falling blood pressure can indicate internal bleeding. And so this should be reported immediately. Patient could be developing a hemothorax. Oxygen, of course, we need to make sure the patient is being oxygenated well, even if they're on a ventilator. Um, let's see, what else? We also want to check for mediastinal shift. So we're assessing the trachea, seeing if it's still at midline, and that they're not developing a tension pneumothorax. All of this should be reported to the physician. We also want to monitor their secretions. If they're thick, yellow, and green or foul smelling, we need to report that because that can point to a pulmonary infection. Chest tubes, we talked about that. Incisions, we want to wash the incisions and make sure there's no local infections, redness, edema, drainage, especially purulent drainage. We want to make sure we making sure that the chest tube is not filling up with blood too fast, and the color of the blood that is draining. Um, Making sure we are taking care of that chest tube, that it doesn't tip over, and that the tubing coming from the patient to the to the container, the drainage device, is not kinked, and that we're not milking the tubing. We're not what is it? Milking it or what's the other term I use? Stripping it. Stripping the tubing, and all that information we talked about as far as the chest tube is concerned. Hopefully, they won't give you guys too much information or questions about that. But just in case, I think you have, for the most part, enough. Remember, when the with the chest tubes, when the lungs, when the lung has reinflated, right? When it has reinflated, you're going to see the water seal. When you inhale, it's going to rise, and when you exhale, it's going to fall. And so they call that titling. TID as in David, ALING. Titling is what we call it. All right, and that's normal. That means at some point they're getting ready to remove the chest tube. Your nursing diagnosis, of course, they're appropriate, and that's it. All right, folks. That lasted a moment. That lasted for about 2 hours and 30 minutes. And so hopefully what we go over in class, it may last about a couple hours as well, because this was a pretty long chapter. So go ahead and listen to this. Tell me what you think about it. Hopefully it is very helpful to you. Thank you so much, everyone.